Welcome to the Learning Lab. My name is Roman Garcia. What we're going to talk about today is how to objectify osteoarthritis of the knee. Now, if you are a patient and you have gone to a doctor's office complaining of knee pain, you know what I'm talking about. The poor level of information that the doctor gives you when the diagnostic tests are read to you. Basically, as it currently stands, the medical community does not understand nor is able to objectify arthritis of the knee. What I'm going to show you today is some metrics that we use in our clinics in order to objectify osteoarthritis of the knee. Because on initial examination, if you're not able to demonstrate objective findings that you can document over and over again, then how can you treat a condition that you are not able to follow its progression objectively? So what I'm going to show you today is some of the metrics that we use in order to objectify osteoarthritis. And I'm going to start off with showing you a picture of one of our typical patients that comes to our clinic. We do not get easy cases. These metrics that I'm going to show you, we've developed them as we've gone along treating patients with osteoarthritis of the knee. And these are metrics that we follow and that demonstrates the progression, either improving or not, of the condition of osteoarthritis. Usually these metrics will improve commensurable with how the patient feels. So as the patient gets better, these metrics that I'm going to show you you start seeing changes in the metrics when we do subsequent evaluations. Now, what I want to show you again is one of our typical conditions here and how we would objectify this condition. And then later I'm going to show you an example of it in real time with my assistant Anna. But what I want to show you first is one of our typical cases here. This is a patient that came to us obviously with knee pain. This person had more pain on the right than he did on the left. We only treated the right knee. Now, this is your typical examination that's given by a doctor. He'll see the x-rays and then he'll tell the patients, you got bone on bone or you've got osteoarthritis, and that's all the information you're going to get. You're not going to get any more in-depth detail about the condition. Now, what you cannot see is these minute metrics that are occurring in these pictures. Everybody's a little bit different. There are some generalities in the metrics, but each patient is a little bit different. And these metrics pinpoint each individual condition based on the amount of arthritis that exists in the patient at the time that they're evaluated. So this is a typical x-ray, and your typical response from an MD would be, well, you've got osteoarthritis, you're bone on bone, and that's pretty much all the information you get. But what I'm going to show you now is more detailed objective studies. Now, a patient like this, these are the metrics that we would do on these films. We've discussed some of these, but I'm gonna emphasize today one particular metric. Now, it is clear that when you see this picture, it represents a knee that's in a knock knee. The knees are coming together and you can kind of appreciate it without really having to develop any kind of geometric markings on the x-ray. But if you do the geometric markings, the knock knee comes out obviously. Obviously, these are the vector lines right here. So just by doing these vector lines right here, we know that this right knee is definitely in a knock knee. When this line crosses the inner half of the bone, of the tibial bone, that represents a knee that's in a knock knee. Now, the interesting thing is that the left knee is not in a knock knee posture. It is tilting towards knock knee, but it's not, because you see the vector line here. But the discussion for today is not these vector lines right here, but these pyramids right here, these triangles, right triangles. These triangles right here. This triangle right here represents the magnitude of load. So if a patient comes to you and we create these triangles, this is the inside, this is the outside. The bigger the triangle is, the more weight-bearing load that side of the knee is being exposed to. Now, it would make sense that an individual who's knock knee like this would have greater magnitudes of loads on the outside part of the knee. This is the outside, this is the inside. And they would have less magnitudes of load on the inside part of the knee. And I think you can appreciate this, but you can definitely see that the outside triangle is larger than the inside triangle. If you go to the knee that's less involved, you see a similar pattern. The outside of the triangle is larger than the inside triangle. That means that even on this left knee, the outside part of the knee, since it's tilting towards not knee, this outside triangle is expanding because there's more weight-bearing load on the outside than there is on the inside. Now, we can get and create a mathematical formula of it and objectify it through a mathematical formula. Now, in order for us to get the volume inside the triangle, the formula is very simple. We use this in our clinic just to be absolutely positive that we're objectifying it and we're measuring the volume. Now, in order to get the volume inside a triangle, the formula is very simple. This is the area. This represents the volume inside, and it's A represents the height, B represents the B, and then you just divide it by 2 and it will give you a number. Now, if we were to use this formula on these triangles, the interesting thing, not the interesting, but what we would find out is that the number will be greater here than it would be here. It will be greater here than it would be here. Now, bone, human tissue, live tissue is always adapting to its weight-bearing load. Now, another thing that you can appreciate from using these metrics and objectifying the condition is that you can actually start seeing the bone adapting to these abnormal asymmetrical weight-bearing loads. Now, if you see the difference here between the right and the left knee, this is the inside, this is the outside, you can actually see how, because there's so much load on this outside part, because this knee is a knock knee, this area of the bone, which is the tibial plateau, this is what it's called, is actually atrophying on this person because there's very little weight-bearing load on the inside part of the knee versus the left one where it's more symmetrical. So this area right here on this knee that's not in an extreme knock knee position, it's actually receiving weight-bearing load. So since it's receiving weight-bearing load, it's actually adapting to that load and it's being exposed to weight-bearing loads. So this area right here is more biologically active than this right knee is. There's no biological activity on this knee, on this part of the knee right here. So basically the body is absorbing this medial plateau from this more involved knee. And you can appreciate that only if you actually create metric objective studies of it, such as these. Now, if we were to use this formula, A is equal to AB divided by 2, which will give us the volume of the triangle, we would see that the area, the volume of this space right here would be less than this area right here, which would be more, because there's more tissue volume on this left knee than there is on this right knee. Because of this extreme knock knee, this outer half is getting larger, and this inner half, this tissue right here, this bone tissue, is actually being resolved. It's getting smaller because there's no weight-bearing load. So the tissues are adapting to that low-level load by absorbing this tissue. It doesn't need it, and that's basically why it's being absorbed. Now, what I want to show you now is I want to show you a case here where we know that's in a knock knee. This is Ana, my assistant, and I'm going to show you something. Te me puede acostar. This is the interesting thing about the human body. The human body uses geometric shape and geometric form. Carlos, you can come to me. geometric shape and geometric form based on the weight-bearing load that that joint is exposed to. Now, there's nothing more solid than a triangle, a pyramid-like triangle. Imagine it has a large base and a very narrow apex. That makes the structure very, very solid. It makes it a very potent or a very well-constructed structural support. It's not by accident that the medial, Carlos, come over here again, that the medial and the lateral plateau are kind of shaped like a pyramid shape, just like what you see here. This is not by accident. Evolution has actually created a very solid structural support system as part of the knee joint itself. That's why when you do these metrics, its shape is like a triangle. So now what I'm going to do is I'm going to show you how it is over here. Now this is Anna. This is Anna, my assistant. We know from history of other videos we've done, we know that Anna is in a knock-knee posture. Carlos, well, let's go here to her x-ray. This is Anna's x-ray right here. This is of her left knee. It's a little bit light, but you can appreciate it here. These are this line right here, this is the vector line. This is the inner half of her tibia right here. This is how her weight-bearing load falls. You can see that the weight-bearing load is falling real close to the inside part of the tibia. That means her knee is in a knock-knee posture. We know that already. And again, and the x-rays prove that. If we were to do the triangles here, we would see that the triangle on the outer half would be larger than the triangle on the inner half, right over here. This triangle right here would be larger. So this is how it would be shaped. This is the geometric form of Anna's knee. Now, what I did is that I created those triangles on her knee so you can appreciate it. When Anna is standing, Anna, do this. Anna, párate. Stand right over here. Carlos, we can get this. When Anna stands, we know that she's in a knock-knee pattern. All the weight-bearing, most of her weight-bearing load is on the outside and very little on the inside. That's why the triangle is larger on the outside than it is on the inside, because most of her weight-bearing load is out here. Now, when somebody stands, no matter whether you're in knock-knee, bow-legged, or in neutral, the weight of the body falls in this direction right here. It falls like this. Falls straight in like this. It is no accident that the tibial plateaus are structurally shaped, functionally shaped in a triangle pattern. Se me puede sentar aquí ahora. Acuéstate. So this is the interesting thing. The weight-bearing load falls in this direction right here. Falls straight down like this. It's not straight down. It's kind of like it's kind of like angled. It's angled like this. That is why these pyramid geometric structural support system looks like a pyramid, because the base is it's extremely stable. So this is by no accident. Evolution has created a pyramid support structure of the tibia. But the problem is that if you're in knock-knee or you're in bow-legged, these triangles become asymmetrical. So the idea is that when somebody comes to you and they're experiencing knee pains and they have arthritis, it is extremely important for you to objectify the sizes of these triangles, whether one triangle is larger than the other, because only by doing that and objectifying it and creating a profile which is unique to the individual, any subsequent treatment that you do, you are basically just relying on the patient's experiences of pain relief or not. And that's basically all that the doctors go by. Unless you are able to objectify the condition itself, you really do not know if what you are doing is actually creating actual, real improvements in the state of the tissue. And therein is where the problem lies in our current methods of treating osteoarthritis of the knee. We're not getting good examinations. We're not getting good evaluations. And there is where the problem lies. If we're able to create a solid baseline of these conditions, then we can start knowing what protocols work and which ones do not by just simply following the metrics that you created, that you established on initial examination. And it's not a simple metric to have developed. It took years of observation, of trial and errors to develop it, but this is as close as you can get to objectifying a condition. So if any of you have any questions about this video, about what I just discussed, if you have any opinions, if you live in the South Florida area, you want to visit the facility, there's always a phone number. There's always an email address that I can be reached for any questions that you may have. Again, anybody who's watching this video, I want to thank you. Until next time.